I'm going to put you in the spotlight, Rabbi.
Okay.
Okay. There you go.
Okay, great. Let me just move this back a little bit. Welcome, everyone, and thanks for making the time to be with us this evening. We are going to be talking about matters of life and death tonight, and I'm not given to hyperbole here. I think all of us know that we have a tradition that focuses on healing, and that it goes all the way back to the earliest moments of the Torah. We see that Moses and Miriam and Aaron find themselves in a very difficult situation. Miriam is ill and Moses is fearful for his life, and he says to God, El na rifana, God, please heal her. And so we understand that from this, we can be part of the healing process. In the book of Leviticus, it says, you shall live by them. So when it comes to Jewish law, we do everything to promote healing, including pikuach nefesh. We suspend any holiday, any law to save a life, with the exception of murder and things like that. In our tradition, faith and healing go hand in hand. And for us, healing is more than an art form, it is a mitzvah. Rambam, perhaps our greatest known physician besides Jonas Salk, he writes about, in some detail by the way, the obligation of a physician. And that's a very powerful thing for us to begin with. It is a chiyuv, it is an obligation to heal. But we are living in a pandemic, in a very, very challenging time. What can Jewish texts teach us? Well, they can offer us information, a wealth of information about how a community shares its resources, how we think about life and death choices. So we are in a pandemic, and we base ourselves on a tradition that focuses on healing. And it seemed to us that we should spend an evening talking about where we are, what we have seen and during this coronavirus pandemic, and what we can learn and what we might expect as we go forward. And to help us with this, we are really so fortunate to be able to reach into our own congregation and reap the benefits of having true experts in the field. Dani Lazar is Executive Director of Research, Evaluation, and Innovation at Access Community Health Network. Access operates 35 community health center locations across the Chicago metropolitan area and is one of the largest federally funded health center networks in the country, serving 175,000 patients each year, including 30,000 uninsured individuals. Serving Access in its underserved communities for more than a decade, Dani has dedicated her efforts to develop long-term sustainable programs that increase access to care and address health inequity, which of course are very much on our minds today. Her most notable work has addressed extremely high-risk populations, people at risk for HIV, men and women with mental health and substance abuse issues, people emerging from the criminal justice system, women at high risk for breast cancer mortality, and other significant health disparities. In her role, Dani has created and shaped Access' overarching strategy for research, evaluation, and innovation. She also serves as director of the Access Center for Discovery and Learning, a National Institute of Health-funded translational research center located on the south side of Chicago. Finally, Dani is a member of the statewide COVID-19 Health Equity Team and the citywide Racial Equity Response Team Provider Work Group. She holds a master's degree in public policy from the University of Chicago and is completing her doctorate in public health at the University of Illinois, Chicago. Dani's married to Jay and is the mother of Ayelet and Josh. She's a very active member of our congregation. She has helped to lead our La'atid program, our revisioning of our religious school, currently serves as Executive Vice President of our board, and we are so grateful, Dani, for all that you do and for making time this evening to join us. Second, we welcome Dr. Curtis Weiss. Kurt was born and raised in Chicago. I knew him when, and his family joined Anshe Emet when he was in high school. He wanted to be part of the youth program and really made quite an impression here. And he has continued that tradition as an adult. Kurt went to Yale for college, medical school, and residency. And he then went on to Northwestern for a pulmonary critical care fellowship. Currently, Kurt is ICU director at North Shore. His clinical practice is in critical care as well as pulmonary issues. He also does critical care research, and he's been one of the leaders of North Shore's COVID response, especially its ICU response. He's married to Emma and is the father to Micah, Zelma, and Charles, and we thank you both for being with us this evening. And for those who are part of our conversation this evening, and we have nearly 60 people joining us, please make use of the chat function. And if you can ask questions, you can make comments, you can remind people of how badly they need a haircut, whatever you'd like. But I'm gonna begin by addressing, we're gonna talk about the future. But before we get there, I wanna kind of just talk about a little bit about your experiences as we've gone through this kind of DC during COVID-19 before we get to what you're seeing after COVID-19. So Dani, I'm gonna ask you a little bit, if you'd start, just by talking a little bit about your experience during this pandemic and maybe some of the things that you've learned along the way.
Sure. Thank you. Can you hear me okay?
Yes.
Thanks. I'll try and use my outside voice. You know, it's interesting, and I was reflecting on this because I'm sure, like Curtis, it feels still like we're very much in the middle of it. But we started to become aware of what was going on, I think, in January, those of us that following this, and certainly in late February, early March at Access, we had started planning for this in January, knowing that this would probably hit our shores sometime soon. And really, I think something that a lot of people don't recognize about this is how fast moving this was and how quickly things were happening. So the first case in Illinois was the beginning of March, and then we saw it just really go off the charts, and there was a lot of learning that was going on as we were trying to change things. So the city of Chicago said, all right, we're going to set, and the state of Illinois had shelter in place in March 17th. At our health centers, our patients were still coming in, which we want them to do. We want to have access to care, but what we were seeing is things like we didn't have access to PPE, so we weren't able to mask everyone, and we very quickly realized that we needed to reduce staffing. And so what I saw during the pandemic, at least at the very beginning, across federally qualified health centers and other community services, is this rapid change in the way that we practice care for our patients. And so some of the things we talk about, we set up, some of you may have used telehealth in the past. We didn't have it. A lot of our sister health centers didn't have it. And you see very rapidly in March and April, the shift from community health perspective of setting up telehealth so we could still provide care for our patients. And one of the things that really stands out to me, so we had I think most hospitals and health centers have incident command teams. I know there's one for the state and the city. And the very first question every day that came up was, where can we send our patients for testing? And this was something that was so difficult. We were calling every day, trying to understand where people could go, where could we send them, how do we get information? And that stands out very clearly in my mind, because when I think about health disparities and how this pandemic, and I think a lot of us have seen this, really blown the roof off of seeing what's going on. It started for us in not even being able to get our patients tested. At one point, and I remember having this conversation with some friends, we had 800 masks for 35 plus sites. That was all we had left with whatever was in the health centers. And that was really the start of it. And some of that has changed quite significantly. And so when I reflect on it, I think where we are now in the 3 to 4 month period is a very different place. We understand a lot more about transmission. Certainly, if you look at the numbers in Chicago and Illinois, we've brought things down quite a bit. There's widespread testing available. And I think some of the questions now that are coming up are, okay, we did all of this. We now have a better grip on how to test, how to get people in for care. I'm sure, Curtis, you'll talk about how you care for people in the hospital. But now I think from a healthcare perspective, we're starting to think about, what does this new normal look like as we start to move into this next phase of the pandemic? And so some of the things we've been thinking about are, how do we make sure that our pediatric patients get immunizations, right? Bringing them back into the fold. So I think that's happened. The other thing that really stands out to me, and you see this in different communities, is there was a banding together of experts and people calling each other and drawing on expertise and what are you learning and what do you see, that I don't think has happened in other situations, that there was so much cross collaboration in institutions that I think is remarkable, and how quickly that happened. So even over the past month, as we've seen all of this unrest, the health systems and the rapid response team that I sit on, we quickly shifted and we said, okay, well, what do we need to get to our communities? So it was, all right, there are no pharmacies. Let's all call the pharmaceutical companies and Walgreens and make sure that they're going to reopen. So I think you're seeing also a shift in some of the ways that hospital systems and community health relate to each other as well. And hopefully that continues.
Right. So we've seen this growth of telemedicine, which is only going to grow and continue. And hopefully the collaboration will also continue on into the future as well. Kurt, you've been on the ground in remarkable ways. You and I have had conversations at the very beginning of the pandemic, and you shared the harrowing situations you've been in. Would you share some of your experience with us, please, during this
Sure.
COVID-19 and some of the things that you've learned along the way?
Sure, absolutely. So I think, I would echo what Dani said. We started really concentrating and focusing on this issue back in January when we saw what was happening in China, and then in late January, early February, what was happening in Italy. And I think even before there were, the first few cases in the US were people who had traveled, people who had gone on a cruise in the East Asian Sea. And I think that even though we only had a few cases in the United States, we saw how this pandemic had overcome a very large city in China and had overcome much of northern Italy. And so I think that we also were focusing on it very early. And, a month before we had our first patient with COVID, either as an outpatient in our system or in the hospital. And then things things changed very, very quickly at the beginning of March, sort of the beginning to middle of March. They changed very quickly statewide, and certainly within our system. As Dani was saying, we had the first cases in Illinois at the beginning of March, and by 2 weeks later, the governor was shutting down the state. And so we had that experience as well. We spent a lot of time planning, and for us, the real issue was how do we reorganize medical care, both for COVID patients and for traditional patients, in sort of on the fly, with no manual, no rule books, and no prior experience having to do this. And so I think that we had to do a lot of it on the fly. We had daily meetings. I spent from the middle of March until just the middle of April, 4 to 5 hours of phone calls a day, just discussing operational planning, and then there was a patient care as well. And so we really had to reorganize our philosophy of medical care very, very quickly. I mean, thankfully, both the public and the state and the federal sort of regulatory systems were very understanding about the situation. But I think that because things changed so quickly, we really had significant concerns. At the beginning, there were a lot of unknowns, and there are still a lot of unknowns. And talking about the future, which I know we're going to spend a lot of time on, there are quite a few unknowns. But at the beginning, everything was unknown, including what if we had a situation like Northern Italy, where they had built basically Army field hospitals and had hundreds and hundreds of patients who were being cared for in these medical tents, these very large medical tents, without proper equipment, without clinicians who were experienced in taking care of patients with infectious diseases or pulmonary diseases or critical care. And we were very concerned about that at North Shore. And so as this all started, one of the things I reached out to Rabbi Siegel about was, okay, what is our stance, or what are the different kind of philosophical perspectives on what if we run out of ventilators? How do we take care of patients who need ventilators when we don't have any ventilators? And fortunately, it never got to that point in Illinois, although there was a 2-week period where we really were very concerned at the end of March, early April, that we would run out of ICU beds and run out of ventilators. But thankfully, that didn't come to pass so far. I think that those were the kinds of planning that we had to deal with. And then we did have a surge of patients. We had to basically convert there are 4 hospitals in our system. We had to convert one of those hospitals into a COVID-only hospital for a 2-month period. We had an ICU at that hospital that could take care of 21 patients, which we filled up very quickly with COVID patients, and then had to build an entirely new ICU in the emergency department because we maxed out at 45 COVID patients who were on ventilators at our hospital. So we had to do a lot of this planning, again, on the fly, with a lot of collaboration, a lot of sort of operationalization, and with a lot of experience in clinical medicine, but not much experience in how to deal with this kind of true emergency. And I think that our outcomes are very similar to the outcomes that you read about in the news. Our system-wide outcomes are very good. Our patients who come to the ICU are very, very sick with this disease. Patients who are on a ventilator, the majority of them die. And that's something that we had never experienced before. I have never experienced an ICU with a mortality rate that was pushing 50 or 60% of patients, which is catastrophe. And I think that that's what we were dealing with and what we're still dealing with, although the numbers have gotten better in terms of the sheer number of patients.
Did you find yourself having to make life and death choices between patients and resources?
So thankfully, we did not. We were able to do a lot of sort of non-traditional ways of building resources, whether it was PPE or just the engineering of the hospital. We had to change the airflow of the entire hospital to make it a negative pressure, sort of isolated hospital. We had enough ventilators, and we were able to obtain a lot of ventilators, including ventilators from people at home. So some people at home are on CPAP or BiPAP devices, which are basically ventilators for things like sleep apnea. And we were able to obtain a few of those to tide us over, which we were able to do. So I think we were operating in a position of not knowing what was going to happen, and we came close to a situation where we were going to have to think about allocating resources. We developed a plan to do that. We had a lot of sort of discussions with our ethics committee and with a lot of other providers in our system about what to do in cases of resource allocation. We had to make very tough decisions about what we call goals of care. You know, if a patient with COVID pneumonia is intubated in the ICU, if that patient were to suffer a cardiac arrest and need CPR, would we do CPR? How do we balance the potential benefit to the patient with, which may or may not be good at that point, with the risk of exposure to the healthcare providers that are taking care of that patient? So these were discussions that were, again, I've had goals of care discussions, unfortunately, throughout my career, but not on this scale and not in this way. And so it was really an eye opener. And then on top of that, I had to come home and I couldn't go anywhere. I came home, and my wife, has an essential job as well, and she had to work, and she worked at home with young children running around, which is just crazy. But we couldn't.
So how did you handle?
Yeah.
What was the first thing you did when you got home? I mean, talk about that for a second.
I took a very deep breath. Well, I took a shower. So our procedure is to, if you've seen COVID patients, is to take a shower when you're done at work, change into clean scrubs, go home, take a second shower. So I would always take my second shower the first thing I got home, and not touch anything, and then go have dinner or try to see the kids if it wasn't too late. We also had very late shifts that we were doing, but then I would just sort of fall asleep. It was very tiring. I talked to my family quite a bit, both my wife Emma and kids, and my extended family as well. But it's surreal. Everyone is dealing with this issue at home, and either not working or working from home. But I had to, this is a 24/7 sort of situation for those of us who are, have it as part of their work life as well. And so it was surreal. Driving on the highway and seeing no cars. I mean, this is a completely different world, I think, than existed 4 months ago.
There's no question. First of all, I want to thank you and Dani for your life-saving work. There's one question I want to just fit in here from Mia Siegel. How helpful are healthcare powers of attorney to doctors when making these healthcare decisions for patients?
I mean, so I think that they're they're indispensable. I think that when a patient can't speak for him or herself, having a close family member be able to speak for that patient is indispensable to us. It's a person, a healthcare power of attorney is someone who is, usually a family member or a close friend who knows that person. And we can provide medical expertise and advice and insight, but I can't provide the patient perspective. I have to learn the patient perspective. And so, if a patient can't talk to me, then having a power of attorney to help reflect that patient's wishes, be able to speak for that patient, this patient he or she would not want this or would want this, and can provide that insight is really indispensable to us.
Yeah. So I want to, before we begin to talk about the city reopening and all of that, and the synagogue reopening, and I want to raise the question of how prepared are we if, God forbid, there's a second wave? Dani, How prepared will we be in this country if, God forbid, there's a second wave of COVID-19?
It's a good question and a tough one. I mean, I certainly having gone through this experience, and I think like Curtis, the number of meetings about it is just astounding. 5-6 hours a day, morning, evening. But, you know, I think that there's some things that we've learned, certainly at Access. What we're doing now is going, okay, we had this extraordinary experience of completely changing the way that we practice in response to this. So for instance, telehealth, we've been talking about it for 5 years, and it just took this kind of push to make it happen. You know, so I think a lot of health systems are reflecting on it and going, what were the key things that we're missing? Testing, PPE, preparedness. How quickly can we get our staff out of the health centers? How quickly can we get communication for our patients? What does that look like? You know, so I think the systems are reflecting on it. In terms of long term, you would hope that we've learned quite a bit. I think in looking at the response of the city and the state that we live in, I think we've done a tremendous job in really saying, okay, we need to figure it out. We're going to put up testing sites. We don't know if this is going to work, and just trying to move quickly. I'm not sure if the rest of the country really recognizes at this point, depending on where you are, how quickly this situation changes. And so when you think about a wave, if you will, of a pandemic, right? It started at the coasts, travel made it come to some of the bigger cities. We saw this explosion, and just now we're starting to see this increase in some areas that originally went, oh, this is not a problem. But you think about someplace that's rural that maybe has, I don't know, Curtis, you would know better than I do, 20, 30 beds. If a wave hits that community and they're not prepared, we have some problems. And I'm not sure that as a nation, we're prepared for a national response, which I think could have mitigated some of the severity of the impact of the pandemic. And that's a real concern. I mean, where I work, and it really is true, the PPE issue was, I can't even tell you. Jay, my husband, found a box of 500 masks in his branch. He called me. This was in like the third, fourth week of March. He called me and he said, Dani, I found these masks. Can you use them? I texted a copy of the photo to our head of clinical education and infection control, and she said, please, can you bring them down now? That 500 masks, that was part of what we distributed. I mean, we weren't able to do some of the things that we knew could be infection control appropriate, universal masking, without masks. So while I think the state and the city is probably better prepared in Illinois than we were, I'm not sure nationally if we're ready for another pandemic or another wave. I also think there's a lot of misinformation that's out there. I think there's a sense that this is maybe not so serious for some people. And while we've all become at-home epidemiologists, sometimes I think a lot of what I spend my time doing is, well, yes, but not quite. And I think that's just the nature of human beings as well. And of course, we're social creatures. So saying to an entire country, you're going to have to stop doing things that come natural to you and hugging people and being together is hard.
Okay. So let me pick up on Alice Ginsburg's question. She said, and then we're going to turn our attention to Curtis. But as long as we're on the subject, I want to stay there. So Alice asks, what change in political approach would be helpful at this point in dealing with COVID-19?
Mm-hmm. I don't know if I want to say political. I'm going to take it from a public health perspective. I think what we need to do is we need to believe our experts. And we have to also take a step back and remember that the science is changing rapidly. I don't know anyone else who's on the call who has been involved in clinical trials or vaccine development. The pace at which this is happening, where there are clinical trials going up for COVID-related interventions, is astounding. I think the political approach needs to be very much, this is my opinion, I am not speaking for Access. We as a nation are confronting something that we haven't ever confronted before. A pandemic is just different. This is not a pocket of things. And we need to come together as a nation and listen to our scientists and our public health folks and believe them when they say that it is safest for us to do these things. This is what we think is really the timeline, and weighing that with some of these other priorities, which are important as well.
Right.
You know, we ran town halls around testing when we opened up our testing sites on the south side and the west side. And folks said, yeah, that's great. Yeah, we'll get tested, but I've been furloughed. I'm worried about how to feed my family. These are issues. And certainly in some of our immigrant communities, without going down too far a path, the whole environment of fear is really at play here, where people are concerned about, if I come and get tested, what's going to happen to me? Not so much from a healthcare perspective, but from these other things. And it's a problem.
Right. So the pandemic has really cast a harsh light on a whole variety of societal ills that we need to face as a country. Well, thank you for those answers. Thank you. And thank you for what you're doing. Curtis, would you talk a little bit about how prepared do you think we are? There's also a question about steroids that came up. So if you could address that too, that would be great.
Sure. So I'll address the steroid question first. That's a great question. So as Dani said, the pace at which clinical trials are being set up, performed, and results being released is very unusual, which is a good thing and sometimes a bad thing. So in a bad way, there have been studies that have been published that have now been retracted. There are studies that have been published where the results, or the studies that have not been published, but the results have been released in press statements, in press releases, which is the question about steroids. So there's a long history of the use of studies that have looked at the use of steroids, systemic steroids like prednisone or the equivalents of prednisone in patients with pneumonia, viral pneumonia, bacterial pneumonia, and in patients in the intensive care unit with a condition called ARDS, acute respiratory distress syndrome, which is something I do a lot of research with the NIH on ARDS. So steroids have had their ups and downs in critical care, in pulmonary medicine, and in infectious disease medicine. And there was a press release yesterday from the United Kingdom that the National Health Service there did a large study of thousands of patients showing that, or at least the press release stated that there was a significant mortality benefit with the use of steroids in these in patients who were in the intensive care unit on a ventilator with COVID. Previously, the CDC had recommended against the use of steroids for COVID pneumonia back in February, March, when this all started. And that's based on prior literature. But just echoing the pace of change that we've had locally and that everyone has had. I have a lot of friends, research collaborators across the country. We've all been on the phone. We've all been having emails for the last 36 hours or 48 hours since this came out a couple of days ago. We've had several internal calls at North Shore to discuss this, and we've now decided that we're going to give steroids. We just made this decision yesterday afternoon that in certain populations that we would do this, even without evidence, even without a published study. And that's based on prior literature, and it's based on this press release, and it's also really based on what I said earlier, which is that in the intensive care unit, there's not much to offer in terms of treatment. There's supportive care, but there's not much in terms of treatment. There's steroids maybe now, there's an antiviral medication, remdesivir, and that's pretty much it. And so I think that in the, trying to reach for a treatment, it makes sense based on the literature to provide something like steroids, even though we don't have really published results yet. Getting back to the question of, are we prepared again? I think, I would say what I said before, which is that previously everything was an unknown. And I think now we know a few things. I think there's still a lot that's unknown, but I think how we ramp up, how we build, for example, intensive care unit beds, not in an ICU, how we get supplies of PPE, how we get other medical resources, how we staff this huge influx of patients. We had 200 COVID patients, inpatients in our hospital at the peak at the end of April. That required a lot of staffing. Thankfully, all of the surgeries were shut down and everyone's offices were closed. And so we had a lot of physicians and nurses that weren't doing anything. So we could staff them to help see COVID patients. But I think that we've developed, certainly at North Shore and certainly across the state, medical systems have developed the ability to be nimble and flexible and ramp up and ramp down as needed. That's not to say that it will necessarily be successful if we had a surge, certainly if we had anything that was worse than what we had in March and April and May. But I think we have sort of a roadmap for how to do it in a way that we simply didn't have before. But I think, getting back to what Dani said earlier, I really think that what you said about us being social animals is really important. Americans in particular, I think, are very, we have an individualistic strain and we have a community strain. And a lot of times those conflict. And I think we're seeing those conflicts now. And I think, to be political for a second, you could see that, you see rallies of people and you see politicians on the right who want to have large rallies of people and don't wear masks and don't model correct public health behavior. And that's potentially going to increase the risk of COVID. It is going to increase the risk of COVID spread. But then you have other rallies and groups on the left or, the general population
Right.
with the protests, which is a
wonderful thing, but is also, the timing is difficult, I guess, is the way. I think that, because we're social, what I worry about most of all is that we've done this for 3 months. We're now reopening. If we had to reclose things, I just don't know how willing the public will be to doing that.
It's an interesting thing. I was on a national Zoom panel yesterday, happened to be with Pastor Harris, and it was done by an Israel organization here in the United States. And one of the points that was made was how quickly Israelis adapted compared to Americans. And we talked a little bit about the fact that they had, this is a country where everyone serves them in the military. So they're used to taking orders. And so that kind of individualism of America, right, is less pronounced in Israel, much more of a community-based country. So it's an interesting issue about how these kind of ethos, a nation's ethos, can play a role at a time like this. I want to I want to get to a couple of the questions that have been raised. Brian Nagorski asked, it would be nice to get a sense of where Curtis and Dani think this is going. Is this ever going to go away? If we get a vaccine, will it likely be effective enough to stop or only slow the spread? Do you think that the worst populations have been hit first, nursing homes? And are we unfortunately looking to add, are we going to be looking at the same numbers of deaths, 500 to 1,000 deaths a day for months or years? Uplifting question. Dani, what do you think?
Go first on this one. I have some thoughts too, but go ahead.
Sure. So is it ever going to go away? Boy, I hope so. I think that, obviously it will not. I think that the chances of going away will only occur if there's a vaccine. I think that before there's a vaccine, we're going to continue to see these waves up and down. I think we're still in the first wave. I think, what Dani said about hitting the coasts, large cities, coming to large cities in the interior, and then kind of diffusing out to less smaller towns and more rural areas is what's going on right now. And I think we're still in that. We're still there. The big cities are getting better, at least in some areas. But now we're seeing this tremendous spread in rural areas and smaller towns in the interior of the country. So I think we're still in the first wave. I do worry about reopening again, as I said, that things could get worse over the summer with lots of social gatherings. I think that we don't know what's going to happen in the fall or winter. We don't know if this virus is going to behave like influenza, where it will get worse with a seasonal pattern. We don't know if there's going to be an influenza season. Is this virus going to compete with influenza, or are they going to happen together, which would really be a strain on the healthcare system? I think those are some of the unknowns, but I do think that we will still see some degree of up and down, unfortunately, until there is a vaccine. When there is a vaccine, I don't know. I think there is obviously a crusade going on right now to build an effective vaccine with a speed with which, the public health system, I don't think has ever seen in terms of building a vaccine. And I think that hopefully it's successful. The typical time to building a vaccine from scratch is a several year process. It's not something that occurs quickly. Obviously there's hope that will happen now. So I think until that happens, we might be in for these waves that go up and down with hospitalizations and deaths, unfortunately, that go up and down based on social distancing and opening and closing of various parts of our society. Sort of the last question about the worst populations, we saw a very interesting trend in how patients contracted COVID. Initially it was relatively well-off white people who had traveled. Our first patient in our ICU was someone who had gone on a cruise down the Nile River, and that's how they contracted COVID. And then that sort of spread out to those communities. It's then spread to nursing home communities. We had a very large outbreak in the Orthodox community in West Rogers Park around the time of Purim. We then saw significant change as the state shut down. We started seeing larger family units, Hispanic and African American family units who live in larger family units. They were contracting the virus at higher rates then, and that's sort of where we are right now.
Okay.
And so I think it's, those trends are going to continue.
Dani?
Yeah, I would tend to agree. I mean, I agree with Curtis. I think we're still in the first wave. And look, this is a new virus that is changing and we're learning. So I think probably, and this is what most epidemiologists and public health folks are saying, is that we will continue to see these waves. What we always have to recognize is that as society opens up, and we had a lot of conversations about this internally as well. Okay, we're in the city of Chicago, we're in some of the suburbs, but what do we do about the folks that are in states surrounding us? They're open, folks are coming in and out. So it's not, a virus doesn't observe the boundaries of a state. So my expectation is that we're going to see waves. What I hope is that there are enough people that continue to follow good public health practice. The one thing that we do know about this virus is that it is pretty easy to kill. That's why washing hands is so important. Hand sanitizer, not touching your face. That's why you hear us public health folk go on and on and on about this. So if we can continue, even if some of the social distancing subsides, if we can get people into these habits, we might be able to at least keep the ebb and flow of the virus a little bit at bay. And that's really my hope.
So Curtis, you gave this great image of driving to North Shore with no traffic.
The one good thing that's to come from the COVID pandemic.
Okay, well, right. I mean, but you're now observing, we're now in level 4, right? How are you both? Just short answers because I want to move forward. But how are you feeling about things opening up? Is it going too quickly? How do you proceed when you're driving or you're walking down the street in your own neighborhood? What's your thoughts?
Yeah, I mean, my initial thoughts are there's a lot of people walking through Lincoln Park in Lakeview who aren't wearing masks, and that is that's the one thing that really terrifies me more than anything. I think getting together with family, being smart about it, social distancing, trying to do outdoor activities. I think outdoor activities are generally it seems like they're much safer than indoor activities, but I do worry about large groups getting together and not at least doing the basics of protective health.
And I'm with you. That's really a lot of what I worry about as well. My sense, and this is what we've heard from our patients, is I still think that I think people are going to be a little bit reticent to go full in, even if the state opens up. But as the time goes on, and as the news cycle, frankly, changes, I think some of that is going to subside. So that's really, like Curtis, I think what concerns me most. I think the healthcare systems have actually figured it out. Certainly, when I talk in our groups about reentry and all these sorts of things, our health centers are maintaining, like the hospitals, universal masking, all of that sort of stuff. I would say probably one of the safest place to be is one of our testing sites. I mean,
right.
We have it down. But I think where I get concerned about is not so much outdoors, but as we go into the fall and winter months, schools, I think, are going to become a real concern. And how do we do that? How do we keep our kids safe?
Okay, well, let me just cut in here really quickly. So just if you're listening, since we're in the baseball season that's not being played, let me at least use a baseball analogy. We normally end these things around 8. We're going to kind of go into extra innings. I'll be careful with the time, but I want to just take advantage of these two wonderful experts and keep the conversation going. Rachel, Lesson asked about contact tracing and your thoughts about that. And Marjorie Rosenbaum was asking about your thoughts about opening schools and and daycare centers and where you think we're at with that. So I'm gonna just we can each one of you can take one of those questions and then we're gonna move forward. And talk a little more about opening the synagogue. I want to get to that too.
Yeah, I can talk a little bit about contact tracing. Contact tracing, obviously, that is the gold standard of communicable disease. And you need a lot of people to do it. So in a community spread, I think it's really difficult. There is a very strong effort right now in the Department of Public Health, both at the state level and the city and the county level, to increase contact tracing. And I think what trying to do is leverage, particularly leveraging community health to try and do that. So I think that's the ideal. But in a community spread situation, contact tracing is hard because there's just a lot of people. So I think what we're going to see with contact tracing is over time using it to very much target outbreaks and then try and trace those people that are impacted and have them socially isolate. But it's very difficult to do right now in a community spread situation. I will say, I think you're going to wind up seeing us take a page from the HIV epidemic, where there's going to be a lot of focused contact tracing within primary care and infectious disease care. So if somebody comes in and they are positive, that in their primary care provision is going to be a little bit about who have you seen, you may want to bring them in for testing. I know that's certainly our approach and what we're doing.
So Curtis, let's ask a question about, since you have young children, what are your thoughts about opening schools?
Yeah.
And let's add and throw in camps as well.
Yeah. So again, I think it's a balance. You know, my medical hat, my public health hat is that you know, daycares, preschools are petri dishes, and they have been always. And here's another thing that can spread around very quickly. You know, but as you know, we're a family where my wife and I have to work. And so we have to do something with our kids, and we would, you know, want them to have that kind of socialization. So it's a really tough balance to balance. You know, right now we have our youngest, who's 21 months. We have him at home. We just our daughter, who's 3. Her preschool. She's turning 4 in a few days. Her preschool just reopened, and she's there this summer, and we're hopeful. And she's starting at Bernard Zell in the fall. So, you know, I hope it's good. I hope it works out. But you know, we have a 10-year-old who just finished 4th grade and is sort of off for the summer, so we don't have to really worry about him much. But yeah, it's a big concern, and I'm not sure how to balance, you know, our personal needs, the needs of our family, with the public health needs. It's a very difficult question.
Very, very
right.
tough.
And camp is, you know, the whole thing is just it's so difficult. Well, let's talk a little bit about reopening Anshe Emet. I served on the mayor's task force for faith leaders, and so I was very much part of the conversations. And at the beginning, faith leaders were very much all on board, but as time went on, there was a much greater push to open faster. And so we're now at a point where, in theory, we could have as many as 50 people at Anshe Emet at a service. But you know, we're taking a very slow approach here. And again, I want to focus on excuse me, the notion of pikuach nefesh, and the whole notion of we have to live by these laws and not put people at risk. And so our approach is very methodical. Dani, you serve on the committee, but let's talk about that. And as healthcare professionals, what are your thoughts about opening Anshe Emet and how to go forward? Dani, let's start with you.
I think, you know, and thank you, Rabbi. And I do want to acknowledge that we have Libby Alpern and other experts, Seymour Turner. There's a lot of very thoughtful people contributing to this. I think that the primary or the guidepost to me is go slow, right? And go safe. So we're always trying to think about what can we do that is within the boundaries of what would be the most safe for the most people. And so early on, it's, you know, I think we came up with this, all right, you know, the city's in phase 3, we're going to do phase 3, phase 3A, phase 3B, in phase 3C, and really trying to think about general situations. So the first has to be, how do we bring the staff back in safely, right? Then how do we think about the next piece in a small group being together? And then how do we use that to learn and build towards these larger groups? And I think the consensus very much is that it's a prudent way of doing it. It allows us to learn. And we want to make sure that we're doing this in a way that is not just about, adhering to the most specific guidelines, but also what is right for Anshe Emet and the way that we want to come together as a community. And so balancing those two things is, to me, what we always have to think about, but leading with first, how can we be safest, thinking about the range of people that we have to care about in our community. So I think that's what comes to mind the most. The other thing, and Rabbi, you and I have talked about this a little bit in some previous discussions, I think what we've discovered is that our community goes well beyond the boundaries of the building. And so when we think about what happens next week, next month, next year, how do we reimagine the way that we come together, knowing that this is going to be with us for a while? So I think learning as we go and learning from other communities is also really important.
Yeah, the issue of being a community without walls or semi-permeable walls is a very powerful image. We'll come back to the high holidays in a minute, but Curtis, do you want to add it? Do you want to weigh in, please?
Yeah, I was just going to talk about the high holidays, but I can wait. No, I think, I think what I've learned is that having guideposts and having a very clear order of operations is really important. The state has these very general guidelines and very general milestones, and that works for a unit as large as the state. At North Shore, we have system-wide milestones and guideposts for various reopenings or closings or whatever. But then even within North Shore, we've got all these different parts that have their own kind of even more detailed lists and levels of different activities. And so I think that's the most important thing, developing a system of guideposts. If this happens, then this will happen. If this happens, then this will happen. And being able to stick to that, being deliberative and thoughtful about creating that and then sticking to it is, I think, really crucially important. And the other thing I would say is thinking outside the box. So, while indoor activities right now, at least, are still really problematic, that's hopefully going to get better, but outdoor activities are far less problematic. And so, are there ways to adapt Anshe Emet's MO to the reality of the pandemic situation, where outdoor activities are generally a bit safer than indoor activities, and that that can manifest in many different ways, whether it's services outside or large group meetings outside. I think that there's lots of creative ways, and being creative and being adaptive to the pandemic, to the reality of the pandemic, I think is another crucial aspect of this.
We are very much involved in that conversation, but remember, and I know all of us have, various levels of Zoom fatigue. But one of the nice things about Zoom is that you can see each other's faces. When we come together in the congregation, people will be required to wear masks. Rachel raised the question about singing, and so much of the communal activity is about singing, which is one of the more effective ways of kind of spreading COVID-19. And so how do we manage that? So here's an example. In our conversation today about reopening the synagogue, we were discussing best practices and people not singing the blessings over the Torah, placing people at a distance from the Torah and the Torah reader, right? You know, you not using a yod, right, a pointer when you use but congregations that have invested in metal chopsticks, right? And so they kind of purify them, or, you know, they clean them well. So it's the beginning of a long road. And as I've mentioned in some of our other conversations, you know, we can't even estimate, you know, what a powerful tool a shofar can be to spread someone's germs, right? So how do we do that? And we are coming up with all kinds of plans, but so pay attention to what we're trying to do and how many people can come and who can come and what's the age bracket for who can actually come into the building and how would we do a service outside. We're going to use the summer to do some experimentation. It's a really good time to do that and kind of figure it out, so that by the high holidays, we're going to be shooting to have the greatest number of people, which will be, you know, 50 people in a service. And how many rooms can we use, and how does the structure help us? These are all really, really very serious questions that are very much on our minds. Go ahead, Dani. You want to continue?
No. I agree. I mean, I think this is really the time to lean into being creative, and I think one of the things that that I've learned that has been really remarkable from the healthcare community, and certainly during the past month, is how creative people can actually be and how adaptable we can be. And I think we can apply that to thinking about bringing people back together, services, the high holidays. You know, if Rabbi Chenkin Gould has said a number of times in some of our meetings, if we think about, for instance, a sanctuary as a blank slate, what could it look like? And I think as long as everybody is with us and understanding that this is going to be new, and it's going to feel different, but maybe there are some things that work better.
Mm-hmm.
You know, we don't know. I know we've you know, on Saturday morning Shabbat services, and you look at the number of people that come in, or the hub. What has been beautiful is Jay and I have been attending Havdalah almost every week, or Jay is a little bit more consistent than I am, but we usually don't do that with everybody. Or being able to bring other people who maybe would not be able to travel to celebrate. There are some things that are happening that are breaking some of the norms of community that we may be able to lean into as well.
I love the idea of community without walls that you mentioned earlier. You know, I think that being creative is not just about having, you know, services outside, you know, in a park, although that's potentially part of it, but it's also, like, how can we, you know, this is such a profound, I mean, it is really, you know, this is the first time I have really thought over the last few months about, okay, what do Rosh Hashanah and Yom Kippur look like this year? And that's, you know, hearing that all of these issues is really, it's really overwhelming. It's really a profound change and a sad, sad change. And so how do you make some kind of good out of it is such an important part of this. And I think, you know, so for example, you know, how do you make good out of Sukkot when you have a community sukkah at the shul and it can't be open because there's too many people and it's too close quarters? So, you know, we've gone and had dinner there every year for the last 5 or 7 or 8 years. And if we can't do that this year, what do? Well, maybe we build a sukkah at home, you know, like, and that's maybe some little good that comes out of it. And maybe I'm sort of grasping for things, but I think that because of this degree of change and difference from our normal lives, you know, how do we create that new normal in a positive way? I think is an important way to try to deal with it.
I think that was very well said. Thank you. Just in closing tonight, can you both give us a silver lining story? Something that speaks to kind of just a very positive story from your work, something that touched your soul, that, you know, brought a lot of light into a dark moment. Dani, would you start?
Sure. I think there are two things that you know, kind of combined for me. Certainly over the past month, which some of these weeks were incredibly difficult. One of our health centers was not able to be reopened for a lot of different reasons. I think what silver lining is, and I come back to this all the time in my work, is that people are good and they're committed to making change. And I always look at my work in public health and community health as social justice. And I think, as we talked about at the beginning, this pandemic has really put a very bright light, at least for me, and a lot of people, on some of the inequities that happen and that exploded over the past month. And what I saw immediately after was people coming together and saying, it doesn't need to be this way. And so when the call came out that, and I was on the phone with one of my staff, and she was so upset because she lives on the South Side. There was a lot going on in her neighborhood. And one of my team members called her and said, what do you need? And come to my house. And I see this and I hear this over and over and over again, with people reaching out to each other, and communities coming together to help each other through this pandemic. We just, and I will share with you in closing, this is just a beautiful thing. So for our women who are pregnant, a lot of times, and a lot of them give birth on the West Side at Sinai Hospital, were telling us that they didn't have masks. And so there was a huge effort that was led by some folks at UIC and a number of other organizations to gather masks. It's called Masks for Moms. And we distributed over 1,000 masks to women that were giving birth on the West Side. And you know what? That's a beautiful thing. There's a need, we come together, we'll get you what you need. And so that way this incredible moment of having a child can be okay for you.
It's beautiful. Oh, that's beautiful. Thank you so much. Dan, Curtis, would you help close us out with a silver lining story?
Sure. So relatively early on, we had an elderly couple who both came into the ICU, and they were very sick, and they ended up both dying. I promise I'm going to get to a silver lining. But they died within 3 hours of each other, in adjacent rooms. And their family, you know, North Shore very early on restricted visitors to the hospital, as all hospital systems did. But we made exceptions for patients, for family members of patients who were not doing well. We were were dying. And we had this, this plan in place for the family to come in. And the daughter of this couple came in, and she had a very lovely 20 minutes with her mother and a very lovely 20 minutes with her father. And the nurses were extremely appreciative that she had come in. And then she left, and they both died within a few hours of each other. And then she came into the hospital 2 weeks later with COVID, and we took care of her. And actually she had the same nurse that had taken care of her mother. And it was and she did well. She survived and went home. But she had long conversations with the nurse who had taken care of her mother about her mother's last few hours, because she couldn't be there. And it was very meaningful, and it was quite the scene that she had come in as a patient herself and ended up with the same nurse, but she really got a lot of closure, I think, out of that situation. And we've had many stories like that, unfortunately. But I guess that would be one silver lining that I've seen.
There are so many quiet heroes walking around, and you and the two of you are part of that heroic group. So first of all, thanks so much for joining us this evening and speaking so thoughtfully and eloquently and passionately, sharing your experiences, but also thank you for all that you do, and to make this world a healthier place and a better place. And God willing, we'll get past this pandemic and learn the lessons and create a better world. Thanks everyone for being with us tonight, and we'll talk soon. We have another one last session next Thursday night. We're going to be talking about spirituality in a COVID-19 universe, and it'll be our pleasure to speak with Rabbi Karen Kadar and with Jane Shapiro. Hope we'll see you then. Have a great night, everybody.
Thanks, everyone.
Thank you
so much.
Thank you for your time and your efforts. Thank you.
Thank you, Curtis. Thank you, Dani. It was wonderful.
Thanks, Amy.
Curtis, can I ask one more question? Is that okay?
Sure, of course.
So something you said, sorry guys, if you already addressed this, I came on a little late, but this was absolutely wonderful. Curtis, this is Daria. I have a question. So you mentioned that it was really, upsetting when you see people in Lincoln Park and Lakeview walking around without masks. I want to exactly understand. So like if I'm taking my kids out for a walk, so I have a 3-year-old and a newborn. My kid, when I put on a mask on my little one, he's touching his face even more than without the mask.
Yeah.
I also am not wearing a mask because we're not by people. Are we really supposed to be wearing masks when we're just going out for a walk if we're not by people?
Yeah, so I guess I would I would defer to Dani on the specific rule, but I think that the issue is not that you. So if you were, I guess the question, if I was going to a park and it was a very large park and I knew that I was going to be isolated, I would take my mask off if I was in an area where I knew it was large. I had a lot of room around me. I knew that no one was going to come near me. But I think the problem is, with the city, or at least if you're not in a park, like walking down the street, you just don't know, someone coming out of a store, someone rounding the corner near you. And I think that's been my practice, is that if there's any chance that I'm going to be within, 6 feet of someone, or 10 feet of someone, or 20 feet of someone walking down the sidewalk, I have a mask on. I try to have my 4-year-old have a mask on. That's easier said than done. But that's been my practice. But yeah, I mean, if you're out in the middle of Lincoln Park and no one's around you, I obviously that's a different story. Yeah, I would defer though to Dani about the.
Yeah, I think, Curtis, you got it right.
Thank God.
Generally speaking, the recommendation, look, if you go to the park and you're going to be there by yourself, I think it's always good to have a mask by you. You never know what's going to happen. I think in terms of trying to struggle with your little ones to get a mask on, if there's, do your best. And I think that's always going to be the...
I mean, he'll put it, the problem, the little ones, you can put it on them, but the issue is that they're touching their face more with it on than.
Exactly. So I think in that case, it's really, let them not wear it, and hand washing and hand sanitizer becomes important. But I think for you as an adult, if you're in a space, in a park or something, I live right near Revere Park and I go out for a walk, I take a mask with me. 90% of the time there's nobody out there when I walk around, so I don't wear it. But if I see that there's somebody there, I will put it on. I think when you're in a more population dense area, it's best practice, especially if you're by stores and things like that, to wear it. But I think generally speaking, you have it right. And kids are going to do what they're going to do. But as they get older, you want to try and have best practice. So my son is 17. He's a runner. He brings a mask with him. And, if he's running by himself, he doesn't wear it. But if he's on the track and there are other people on the track, he wears it. Because it makes other people, and what he said to me is it's because it makes other people feel more comfortable. So I think there's some of that there as well. Does that answer your question?
So like when I'm walking down the street in Chicago, let's say, and I'm passing someone who is also walking down the street, should I have my mask on?
I think yes.
Okay.
That is best practice. I know if it's not comfortable for you, sometimes you gaiter, but I think it's best practice if somebody is walking towards you to put mask on if you don't have it. If they're not wearing it, you can't do anything about that. Usually what I do is I smile under my mask and I look a little bit away, or I try and walk around. But I recognize that that's not always possible.
So you're saying that you can't contract it with just breathing next to each other?
No, that if you are passing somebody on the street, look, there's always a chance that something can happen. But if you're passing somebody on the street quickly, if you're wearing a mask, that's relatively safe. You have to think about when you're thinking about contracting this, and Curtis, please jump in. You really have to think about the time and the amount of time that you're being exposed, how close you are. And then there's all sorts of science around the amount of the disease that's in the droplets and things like that. So if you're just talking to somebody and you both have masks on, fine. If that person is actively sick and coughing on you, probably not so fine. So I think those are the things that I think about when we're doing this. I don't know, Curtis, if you have something a little bit more medical.
No, yeah, I mean, I think that's exactly right. I think we don't know quite yet about droplet size and how airborne this disease is. The 6 foot rule is really a guess, based on what we understand about other viruses that are similar to coronavirus. So I think that, any exposure is not good, but there's obviously degrees of exposure. If you're walking down the street and someone is not wearing a mask and you don't know when they're going to sneeze, right, or cough, and that's what's problematic, because there's such a force with sneezing and coughing that if you're not wearing a mask, certainly if they're not wearing a mask, it gets into the air, and if you're not wearing a mask, it could you could inhale it. So even if it looks like people are even if it seems okay, I think the risk is that you don't exactly know what the next moment could bring if you're not wearing a mask. Yeah.
I agree with that. And then I think it's really important for everyone to as a public health person, I always think about public health 101. Wash your hands, hand sanitize. You don't have to and again, I don't think you have to go crazy wiping down surfaces, but if you're in a large group setting where there's a lot of people, just be a little bit more mindful of doing that, and wipe down surfaces. In terms of toddlers, they touch everything. There's nothing that you can do about that. And do your best to wipe their hands, and I think that you do the best you can.
Does anybody else have other questions? Okay. Thank you all very much for being part of the program tonight. We appreciate you attending, and we are here for you. If anybody has any other questions that they didn't get answered and wish to have answered, just send an email to myself or Rabbi Siegel, and we'll make sure it gets to the proper people. Thank you again, Curtis and Dani. It was very informative.
Thanks so much.
Very well
Thank
received.
you so much. Have a
Thank
good
you
night,
very much.
everyone.
Yeah.
Good night, everybody.
Thank you. Thank you for answering.
Oh.